so important in continuing the great work that we're doing. Well, it's time for us to continue now, and we're going to have a panel discussion at this time. And it is really wonderful information. I know so many of the people who are participating who do great work throughout the state of Mississippi. This is the ACEs trauma are a social determinant of health. And that is really a crucial topic that we need to talk about, especially in today's time. And the facilitator of this panel discussion is Dr. Mary Coleman. She's Senior Vice President of EmPathways. Phaedra Cole, CEO, Life Health, Region 6 Behavioral Health. Dr. Phyllis Ottley, who's a behavioral scientist with the Division of Violence Prevention, National Center for Injury Prevention Centers for Disease Control and Prevention. Dr. Eric Griggs is the Community Medicine Director of Access Health in New Orleans, Louisiana. Also, we have Rochelle Haynes, that is, who's Vice President of U.S. Social Impact Sesame Workshop. Again, that's Rochelle Haynes. And Caitlin Levine, LMSW, and that's Adverse Childhood Experiences ACE Educator Program Coordinator for the Louisiana Department of Health Bureau of Family Health. So again, let's begin with our panel discussion, and our facilitator for the day. Please welcome Dr. Mary Coleman.
Ms. Wade, Maggie, thank you so much. Dr. Anda, thank you for a very stimulating, thought-provoking presentation. And from your presentation, there are just so many questions, which I'm sure the panelists will address as we move along for the next 50 minutes or so. But just by way of summary from Dr. Anda's presentation, I just made the following notes: that what gets experienced gets wired, that toxic experiences get wired, but so do strength-based experiences. And adversity can also be transmitted vicariously. I think that's important. And it's important really to point out that in addition to the adversity associated with substance abuse, parental divorce, mental illness, battered mothers, and criminal behavior, it's really important to point out how palpable racism is as an adversity throughout the life course, even in utero. And so this biolic stress dose can be very, very big or very, very small. And what we want to do during the conference is to find ways to think about mitigation and prevention. It would be lovely if in the future we could find ways to completely erase ACEs from the experiences of our country, our communities, indeed the world. So I'm really pleased that we have this power-packed panel to begin this conversation, reflecting on the prior presentation. I want to start with one of our panelists who has worked so hard with the Centers for Disease Control in the prevention of ACEs. So I'll start with Phyllis. And Phyllis, ask you, how does your work relate to ACEs prevention or ACEs mitigation? Phyllis, where are you?
I'm over here. Can you hear me?
Yes.
Okay, great, perfect. Thank you so much, Dr. Coleman. Well, as an agency, you know, CDC's overall mission is to protect the health and safety of all Americans. And within the Center for Injury Prevention, and specifically within the Division of Violence Prevention, we are committed to stopping violence before it even occurs. So preventing and mitigating ACEs is a strategic priority for our center. And aspects of ACE prevention and mitigation does cut across each of our injury and violence topics, including substance use, drug overdose, suicide, and other forms of violence. And as we've been discussing this morning, even with Dr. Anda, is that the evidence is very clear that exposures to these potentially traumatic events does increase the risk for other health and social problems, and can have effects that persist for years. So, but the good news is that ACEs are preventable. And so at CDC, we talk about creating and sustaining safe, stable, nurturing relationships and environments for all children. and families so that children can reach their full health and life potential. And preventing ACEs requires us to address really the factors at various levels of the social ecology, at the individual, relational, community, and societal levels, and taking a comprehensive approach. And that means, recognizing that there could be a substantial potential public health impact if we implement a coordinated, comprehensive strategy to prevent ACEs. And so at CDC, one of the ways we're doing this is through a suite of technical packages that we have developed to help states and communities take advantage of the best available evidence to prevent ACEs. And what we know is that policies and programs, those that focus on strengthening economic supports for families, those that are ensuring a healthy and strong start for children, those that are connecting youth to caring adults, and then those that promote the social norms that really protect against violence and adversity, those provide the best opportunity to prevent and mitigate the harmful effects of ACEs. So this year, Congress appropriated $4 million to address ACEs, and the funding was intended to inform how ACEs increase certain risk factors such as substance use, suicide, mental health conditions, and chronic illnesses. And so at CDC, the funding addresses two main areas. First is to enhance ACE surveillance data to help us increase our understanding of the prevalence of ACEs. And then the second is increasing implementation of these prevention strategies to improve outcomes and prevent ACEs. So we have a couple of new funding initiatives. The first is Preventing Adverse Childhood Experiences Data to Action funding initiative. And this is focused on, again, building that state surveillance infrastructure and supporting implementation of data-driven, comprehensive, and evidence-based prevention strategies. And the second is supporting states, some local communities, and tribal organizations to include ACEs questions in their state-based youth risk behavioral surveillance system, so their YRBS. This is to help better monitor and track ACEs. So as a federal agency, we are committed to preventing ACEs before it happens, but also identifying those who are experiencing ACEs and responding to them in trauma-informed ways in order to create the conditions that for strong and thriving families and communities.
So Phyllis, what I'm hearing is that at the CDC, there is a coordinated, comprehensive strategy linked to a set of policies that will ensure, to the extent possible, that early exposure to ACEs is mitigated or prevented.
Yes.
That every child who's experienced even one ACE has access to a caring adult.
Right.
So very, very, very important.
Right.
So I'm sure there will be questions for you. So we're going to just take a note in our notebooks, I hope, and in our memory bank about what you've said to us, and then we're going to move to other panelists to join the conversation.
Sure.
So thanks again. The second question to our panelists is, given the mission of your organization, funding and laws guiding your organization, what work can you do to reduce or erase ACEs? And I think Caitlin or Rochelle will take this question.
Caitlin, would you like to go first? And then I can jump in afterwards.
Okay.
Yeah, that would be great. Thank you. That actually works out perfectly because we, working for the Louisiana Department of Health, we're sort of the next stop downstream from the work that Phyllis does at the CDC. So we take those technical packages and try to distribute them throughout Louisiana so that folks have them and are ready to use them. And the key way that we do this is through the ACE Educator program, which is a train-the-trainer program. We use a presentation that was created by Rob Anda and Laura Porter that gets a wonderful response all across the state. We train folks from different professional fields, different communities, geographically spread throughout Louisiana. And then we support those folks to go out and build up a foundational understanding of ACEs in their own communities and in their own fields, so that we're laying that baseline common understanding and shared language, so that when it comes time to figure out how can we as child advocacy centers, how can we as schools, how can we as juvenile courts or juvenile detention work to recognize that ACEs exist in our field and in the youth we work with, start to recognize the impact it's having on the work that we do, and start to respond and resist re-traumatization. So we've trained 150 professionals to do this, and since 2015, we've given almost 700 presentations to about 15,000 people. So we're reaching a point now where our next step is to really expand our capacity to provide support on implementing some of those things from the technical packages that the CDC provides. So we're working on integrating a greater awareness of ACEs into our injury and violence prevention program, and recognizing, connecting the dots, if you haven't seen it, is a CDC package that we use a lot, about recognizing interrelated risks for violence, shared risk and protective factors for interrelated forms of violence. We're working on building multi-sector partnerships within communities so that folks can work together to create a continuum of care across fields, so that as children and youth move through different settings, as many settings as possible are safe, stable, and nurturing, and as many settings as possible are recognizing ways that they can reduce risk and build up protective factors in a way that builds capacity for the community as a whole and starts to shift social norms towards protection for children, towards shared responsibility, towards destigmatizing trauma and destigmatizing mental health, so that folks are more willing and just more willing to ask for help that's out there, and that help is more accessible and more what they need when they reach out. We work on promoting policies at the system level. That's one of the advantages of being in the Louisiana Department of Health, is that we can reach for some higher level policies that also support, that reduce stress for families, which we know also reduces risk of ACEs. So I could say more, maybe there'll be questions at the end, but I'll pass it off for now.
Yeah, that's a lot of information, and it's really important. You've mentioned the building of protective factors as being so crucial in this challenge we face, and the reduction of stigma. And it just reminded me that in Dr. Anda's presentation, he actually said to us that shame is a public health barrier. And so if we can destigmatize the fact that we all need more support, that the fact that we all likely experience one or more of these ACEs, that will enable people in Louisiana and elsewhere, I suspect, to actually disclose as much as they need to get the support that they need. So thank you so much for that. Rochelle, I know that your role at Sesame Street is a really important one, and is educational, is entertainment, it's everything, but working with vulnerable children to reduce ACEs, how does Sesame Street do that work? And how do you assist in that work as Vice President of US Impact?
Great, thank you so much. I just wanted to say thank you so much for having me today. I'm delighted to participate in this conversation. Special thank you to the Glenn Family Foundation for reaching out to me. We share in everyone's commitment here about how do we improve life outcomes for children and youth, as well as adults that are impacted by ACEs. At Sesame Street, our focus and our mission has been, how do we make sure kids are smarter, stronger, and kinder? We've been doing that since 1969 when we launched our television show, which was truly designed to level the playing field, to bring quality early education resources directly to children who may not be engaged in early education, and using the medium of television and public television to do that. Sesame Street was founded on teaching kids ABCs 1, 2, 3s. It branched into healthy habits, but then we started tackling the tough issues. The first tough issue we tackled was when Mr. Hooper, if folks remember the show, passed away, and we decided to lead head first into talking about grief and death with kids, but doing it from the child's perspective, which is Sesame Street's sweet spot for us, and using Big Bird and trying to explain it to him. And what's been great is folks know about the television show, but like Dr. Coleman touched on, we also are doing work directly in communities. For us, it's how do we take these amazing resources that we've curated and bring them directly to the community-based organizations that are working directly with vulnerable kids and families. So in particular, we have our initiative, which I have the pleasure of leading, called Sesame Street in Communities. Or we do have our website, which I'll drop in the chat. It's sesamestreetincommunities.org. On the website, you'll see we have bilingual resources to help with ABC's 1, 2, 3s, the everyday milestones, healthy habits, but the body of work that I say that has taken off the most for us is our body of work on difficult times and tough topics, which directly connects with ACEs, directly connects with traumatic experiences. We started in 2017 with doing a general topic on trauma. And what we did is we wanted to model for the adults and kids' lives, how do you offer comfort? How do you offer a sense of safety and security? And how do you understand as an adult when a child is having a moment? And so we have this fabulous storybook that I urge all of you to visit our site to see. It's called Comfy Cozy Nest, and Big Bird is having a challenging time, and Alan, our human character, is kind of walking him through how to process his feelings and to model that. And one of the things that's important is it's showing the adults who view the video, how do you comfort a child who's having a moment? And that's what we seek to do. How do we take our beloved Muppets and model these behaviors that we all know are important when children are feeling like they're unsafe? And so for me, with Sesame Street and Communities, it's all about how do we take these resources and connect them? How do we get these into the hands of parents and caregivers, but for providers like all of you who are directly working with kids and families? And we seek to do this in many ways. So how do I go from just having resources that are free on a website to connecting? So we seek to form partnerships in local communities and with national organizations that are serving vulnerable kids and families. We work diligently on how do we train those providers within those organizations? How do we take this wonderful, iconic, trusted brand and put a spotlight on the challenges that families are facing today? Like Dr. Coleman just mentioned in the earlier comments, it's the shame. It's the stigma and the shame. But if Sesame's talking about family homelessness, if Sesame's talking about parental incarceration, if Sesame's talking about parental addiction, it eliminates the shame of it all and allows a community to have a conversation in a safe way. And then we design the resources and tools to couple with that. And so for us, this is about how do we really take our brand and put a spotlight on trauma? We know that so many young kids, especially for us, our target audience is really 0 to 6, are dealing with not just one ACE, but multiple ACEs. And what concerns us is that this is the exact same time that the brain is developing. 90% of the brain develops in the first 5 years of a child's life. And if children are dealing with maternal depression, addiction, food insecurity, homelessness, oh my goodness, I always think of it as a sponge. And I think of young kids and how they absorb everything around, especially when they're learning language. How are they absorbing this toxic stress at the same time? And so for us, how do we mitigate against that? So all of our content that we develop is research-based. We work with experts like all of you to make sure that everything that we do is connecting and has those protective factors in there. And then I have the pleasure of partnering with organizations across the country. We're currently in 12 locations, including in the Mississippi Delta, working with organizations to say, how do we take these resources and add, not to replace, how do we add to what you have? We're not the clinical model and we're not the curriculum. We never seek to be, but we are the family-friendly model with the Muppet that you put that Muppet on a storybook and talk about and have a conversation about parental addiction, and all of a sudden the conversation shifts. And that's what we seek to do. We also seek to build that local capacity on our resources. And for us, it's how do we work together with communities? We never want to partner with communities and come in and be the end all and be all. That's not our role. Our role is to put a spotlight. Our role is to raise awareness. The organizations and groups that stand out to us are those that work as a collective, as Caitlin touched on in her remarks. It's the power of the collective to create a continuum of care for children. You can serve the whole child from prenatal to an adult. Are we all speaking the same language? Are we all trauma-informed aware? Are we all using a trauma-informed lens when we're engaging with families, especially vulnerable children and families? And I think of not only the systems that are designed to deal with ACEs, child welfare systems, abuse and neglect, right? We know they're designed to do that. Social service agencies are the safety net for housing and food security. But I think of the systems that aren't actually designed for kids. With ACEs, school settings not instinctively designed to help children that are going through ACEs. Healthcare settings aren't instinctively designed. Pediatrician wellness visits actually don't always include checks on ACEs, right? The dental clinic. What about court systems? If a family member is going through a court proceeding, family court, drug court, kids are often there because of childcare needs. How do we create spaces within those places where children feel safe and offer some resources? And so what I am excited about with Sesame and the work that we're doing is we're looking for creative ways to bring the systems that are designed to meet ACEs and the systems that aren't instinctively designed. How do we bring everyone together in communities and work together to create a locally level, sort of community level coordinated system of care? And that allows you to serve the whole child. And so I'll stop there and looking forward to additional comments and questions.
Rochelle, I could listen to you and Phyllis and Caitlin all day, but we don't have that luxury, but this was really super wonderful. So for me, the question from your presentation is, what is the continuum of care needed across sectors? How do we build that level of care thoughtfully, consistently across sectors? How do we measure the efficacy of our efforts in terms of that continuum of care? So let's move now to question number 4, and I'd like for all of you to chime in on this question. And question 4 is, what are 2 questions worth tackling related to science? So when one thinks about the science of ACEs, or the science of trauma, or the science of adversity, or even the science of resilience, what 1 or 2 questions come to mind? And I'm inviting all of the panelists to join into this question, Dr. Griggs, as well as Phaedra, to join in the answering of this question.
So with that, I'll start.
Okay.
Thank you again for having me. Hey, Caitlin. My name is Dr. Eric Griggs, Community Medicine Director at Access Health Louisiana. And first of all, let me tackle what is community medicine. It's 3 Ps, it's policy, and it's practice. And let me say to Rochelle, it's really, really amazing to hear Sesame Street from the other side, because I was born in 1969 and been a Sesame Street kid all my life.
Yes.
Caitlin has been an ACE Educator program here in Louisiana. And again, I'm involved in everything you can imagine. I'm on the Children's Cabinet Advisory Board, the co-chair of the Early Childhood Education. The things that are not being emphasized. First of all, I'm going to take the elephant out of the back of the room behind me here, because since March 13th, I've been working 18 hours a day, 7 days a week on COVID-19, television, radio, on the street, you name it. That's all. I just left the TV station. Mm. The real thing, though, is today's the first day of school for a lot of our kids. Mm-hmm. The big sign I've been holding up, waving up and down this entire time is everyone was wondering how to talk to the kids. I'm like, has anyone ever talked to the kids or asked how do they feel? Those exact same things that you're talking about. It's like we're afraid to face our own realities. I didn't realize how many ACEs I had until I took an ACE score, or actually I went to college, but Sesame Street kid, which was the common thread that bound all of us, it's okay for me to talk about, well, you know, it's not okay to go home, for Jimmy to go home right now because his dad's not feeling well. What's missing? The 2 questions is, why aren't we having these real conversations, and why are we afraid to talk to our kids? Because the solutions for the community, particularly for our community, if you want to know what kids need or want, ask them. We have this jargon, we have the social determinants of health, trauma informed, we have all these nice buzzwords that are appropriate for funding and all this other stuff, but Jimmy just wants a popsicle and a hug. So why are we afraid to, the question I have is, are we afraid to take an internal inventory of ourselves individually to really address what we might have might have helped push us, the fuel to help us be so resilient. And that's my second one, I'm being short. That might have fueled the resilience for us to achieve, to be in the room, to be on this panel, to be having these conversations, like real conversations with ourselves, the vulnerability, and really talking to the kids.
Mm.
I said that in one breath. That was good. That was good.
It was wonderful, Eric. Thank you. So resilience is one sort of question that we need to sort of interrogate, I think, in terms of looking at this literature. And the first challenge you raised, Eric, goes to our own discomfort in talking about trauma, in talking about adversity, our own adversity, the adversity that we can see throughout our communities, the adversity associated with COVID and how it's underscored so many inequities, historical inequities throughout our community. So how might we as providers, how might we as coaches or case managers or directors of health and human services, what training might be needed to actually equip folks who really care about reducing ACEs or erasing ACEs? What training might be really necessary to help that along?
I'm not sure if you did that intentionally, but that's a lob right over to Caitlin. Just a super shameless plug for this amazing program that I went through, Caitlin. Hint, hint, Caitlin.
Go ahead, Caitlin, please. She needs to be unmuted. Can you unmute yourself, Caitlin? No. All right.
There we go. I got the, it worked out. So thank you for that, Eric. Eric has been a great part of our work in New Orleans, and I'm hoping to get him more involved in statewide work once COVID-19 calms down a little bit. What we do is we try to train folks from within agencies to train their own peers, because we think that, and that's sort of built into the ACE interface model that we use, is that communities are brilliant at coming up with their own solutions. That's actually a quote from a reporter who she might say that to us all later today. But the idea is that, you know, there's a certain professional capacity to understand how trauma shows up in your setting and how you as a professional can respond to it. But there's also different, you know, we've all had different experiences. We have different workplace cultures. We have different communities that we live and work in. So some element of it has to address where we are actually located and where we are actually coming from. So we think that the best case scenario is for example, the New Orleans Public Library system has about 15 branches, and they wanted as a system to become trauma informed. So we trained some librarians from within the system to train the rest of their staff, and then to hopefully guide a series of conversations to figure out what is the best way for them to become trauma informed. And we're connecting them with other librarians in the state who have been trying to integrate trauma informed practices, but ultimately it's going to look unique for New Orleans, responding to what New Orleans actually experiences compared to other parishes and other parts of the state. So that's my 2 cents, is that it really has to, you know, there's one element that is that professional capacity, and that the sorts of strategies and tools that create the toolkit that you choose from, and then there's drawing from your own wisdom and the strengths-based strategies you already use, and where a particular organization is already coming from, so that you can build on work that's already happening and find your own, you know, address your own challenges and barriers as you go.
Yes, Rochelle, do you want to comment? Or Phyllis, or Phaedra? So let me just say a quick few things in response to what I've heard so far. I'm really clear that one of the things that we might do in terms of the application of science is concede that the first 5 years are truly, truly important in terms of the developing brain. but also recognize the plasticity of the brain. So neuroscientists have told us so much over the last 2 decades about the plasticity of the brain, and that the brain does not completely develop until we're 25 years old. So if you've ever had a teenager, it wouldn't surprise you to learn that their brains were still not fully developed, right? And it wouldn't surprise you to learn the very same thing about a college student who's about 17 and finishes college in about 4 to 6 years and who is approaching 24, 25 years old. So there's that. So the plasticity of the brain is an asset. It gives us an opportunity when we're doing this training to really teach coaches and mentors that ACEs are not destiny. And it gives them the toolkit to actually share self-compassion, to actually share goal setting, to actually share goal achievement, to actually help them appreciate the action steps that they can take today to get to the future that they imagine. So one of the things that Dr. Anda talked about toward the end of his presentation was imagination, right? We're only limited by our imagination in many instances, but we're also limited by the opportunity structure itself. So what if you find a youngster who's had 1 or 2 or more ACEs, and he is reconciling or reckoning with those ACEs, but understanding that he is not his circumstance? That's really important for people to recognize. Yes, I have perhaps a multitude of ACEs, but I am not my circumstance. This is not destiny. But it really often takes a caring adult, just one, to mentor a young person through that period. And it really helps if the system is responsive to these young people. So I want to move now to the very last question that we have for the panelists. What values are currently present in programming and funding systems that support the erasure of ACEs? What values first? Let's take that. What are the values present? And then what programs and interventions have we translated those values into that would support the erasure of ACEs, or at least significant reduction? Eric, you want to start? Can you unmute yourself? No.
Yes,
There you go.
yes, there we go, yes. So first part of the question, our current funding and program system values, at the core, we're worried about the physical well-being, the mental health, the safety of the kids, the growth structure, all those things are at the core of it. And that's what we do. It's an ever-evolving, y'all forgive me, it's an ever-evolving system of jargon-laden policy and buzzwords that kind of get lost in translation at times. It's effective in the fact that the conversation was started, but I say it, but it was a tragic but needed revolutionary event. I don't think the world's ever been as woke as it has been now. So the time for the uncomfortable conversations are over. So there's a platform now for inclusion work, and I'm using jargon now. I'm just going to talk. I'm as much community as I am medicine. I was an English major, so my grandma said I could talk how I need to talk. Now, finally, we can start talking about what we need to talk about. We talk about helping the babies. Well, first we got to check ourselves and make sure we've all done it. I think everyone on this panel in this room has taken the time either to read to kids or talk to kids, and one will just take to you for some reason. And there'll be a story of something that you mentioned, and you'll see yourself in that kid. Identifying that, being able to nurture that, being able to make people feel comfortable in being uncomfortable. Now, here's where it gets fun, in the policy rooms, in the rooms where it comes up for the ACEs conversation, the things for early childhood, but literally, if you can figure out, have a DEI conversation to make people confront their own ACEs, to find their inner kids and let them know that it's okay, they could be helping themselves, because a lot of people, once they get old enough and are able to move as far away from the ACEs as possible and put a gate around the community, never look back. And it's something that they just don't want to deal with, but they're in to do so. So those are the new values. It's a inventory that I'll say again. And look, feeling comfortable. I know I talk about, I didn't know I had any ACEs. I went to college thinking my house, the house I grew up in was 750 square feet. That's about the size of one of the rooms in my basement right now. And I thought you could have told us that we lived in the Beverly Hillbilly mansion as far as I knew. And everybody in the neighborhood was rich because we had everything we needed. So if we can keep our policy hats on, that's why we do the education, that's why we do the work, but then let the real person and the people come out in those closed doors to stand up for you and your friends as a kid. So those values, and literally put them in the experience. There's a DEI experiment where they do with the race for success, standing, take step up, step back. Every single time, I've been the last person standing there, but I'm not the last person to finish. But the race is backwards because that's where resilience comes in. Because if they turn it around, you would be celebrating the people in the back of the room because we're all in the same room. You had all these advantages and I made it, so you can too. So it's real conversations. And when we put that type of empathy into the policies and the programming and the funding, and we take what this community needs and give them what they need and get them to give it back, that's the sender, message, receiver equation. The most important part that's left out is it's feedback. Because the purpose of the whole equation is for us to walk away with a mutual understanding. We might not agree, but there's mutual understanding. It's sender and messenger is the same on both ends. We're not doing that. So from the funding and programming and policy side, we tend to talk down the tower as opposed to talking at the circular table and literally pulling out the kid and being vulnerable. Once we do that, you'll see the programs flourishing. The money's there, and we can make more money to give it there, but to actualize it and actionize it on the ground, those are the values that's needed. Just tapping into the funny looking kid with the big ears and the big feet that like Sesame Street when I'm thinking about who I'm trying to help.
Thank you, Eric. Phyllis, Rochelle, Caitlin, is Phaedra Cole here?
Yes, Dr. Coleman, good morning.
Please, we're waiting to hear your voice. Jump right in.
Sure. I think one of the important values for us, and of course, we're sort of the boots on the ground folks. We're in the trenches, treating the children that have endured many ACEs in their short little lives. And that's the value of coordinated care. Mental health professionals cannot work in a vacuum. These children do not live in a vacuum, and it's going to take all the stakeholders coming together as a unified force to treat these children and identify these children, even more importantly, on the front end, and do some preventative work. There should be no wrong door with regard to identifying and accessing and treating these children, whether it's in the schools. We are very fortunate to have a very robust school-based treatment program in which we have over 60 mental health professionals in the school system, working with that child in the school system, coordinating care with the teachers, the principals, the family members. So that is critical. And we need to shift away from a more traditional in the office model with regard to mental health care and meet that child and their family where they are, going into the communities, going into doctors' offices and helping with referrals and identification, going into the schools, working with the youth courts, with the detention centers. So I think that is something that is very valuable, and we certainly need to shift to that model, a collaborative model.
Mm-hmm. I think that makes a ton of sense. So where are you? Are you in the Delta or where exactly?
That's right. Region 6 Community Health Centers covers a large swath of the Delta, 12 counties, and we're a very rural location. So obviously our children and youth are at greater risk for experiencing ACEs, given the impoverished nature of our catchment area.
Exactly. So one of the things I want you guys just to think about a little bit more is how to strengthen adult capabilities. We know that many of these ACEs arise from the absence of opportunities for parents. And the mother who works 3 and 4 jobs can't be home watching the children, helping them with their homework, providing the dispositions necessary to thrive. Because after all, working 3 and 4 jobs is really quite a challenge. So what, if anything, are you seeing on the horizon in your own venue that could help improve adult capabilities and thereby strengthen parents so that, in fact, there can be some reduction in ACEs. Phyllis, we can't hear you. There you are. Oh, gosh.
Okay,
Yeah.
can you hear me now? Okay,
Yeah.
sorry, I couldn't unmute myself for some reason. It said the host was not allowing you to unmute. I mean, I think one of the things I wanted to say related to that is, and some of the other comments made earlier, is that, you know, at CDC, we're really trying to sort of like obviously address adverse childhood experiences, but also making sure that we're talking about those adverse community environments, right? And so talking about poverty and discrimination and community disruption and all those other kinds of ACEs, you know, so to speak. And so, you know, and that really allows us to shift the whole conversation and narrative around sort of blaming parents for the things that has happened to their children, and more around really addressing those conditions that gives rise to ACEs. And so focusing more on the community and societal level types of prevention that really helps us within just addressing all these other conditions instead of focusing in on what parents may or may not be doing well for their children. And so, I mean, I think, you know, with respect to that, we also have to think about intergenerational and historical trauma, because you know, that's another area that I think we've been trying to focus in on, and a lot of our technical packages, particularly the new one we just released last year on ACEs particularly, you know, we're really trying to focus in on those kinds of historical trauma and those other kinds of events that really contribute to these outcomes in children and in adults. So that's kind of where we've been really going, shifting all of our energies towards more community and societal level types of strategies.
Mm-hmm.
One strategy I wanted to touch on really quickly, Dr. Coleman, is the power of the collective. And I think in what we're finding and hearing from funders is, you know, it's no longer, let me just fund this one initiative and this one intervention with one organization, but how do communities actually organize and come together to leverage their collective power, right? And so that's where I'm finding that's attractive to us as Sesame, to be honest, when we think about ships and as we continue to grow and scale our own program, is we want to partner with communities that have already sort of done the work of sort of saying, wait a minute, we can't tackle this on our own. It's a continuum, prenatal to adulthood. Are all those folks at the table? Have you identified those stakeholders? Have you done the needs assessment? That I find is like the most important thing. The communities that have done the work to figure out where they have gaps, where their needs are, can then prioritize. And then the stakeholders that you bring to the table can play to their expertise based off the gaps that you've identified. And I think the biggest thing about this, and one of our most successful programs, truthfully, with Sesame Street and Communities, is a community in Transylvania County, North Carolina, a small rural town. But why they stand out to me is that they actually created a coalition of 23 different organizations, government organizations, funders, community-based organizations, all with the purpose of serving kids. And they're going to leverage that. So when they do funding, it's through that collaborative. They seek that out together. They did the needs assessment. And I know that the Glenn Family Foundation is doing some work with the Robert Wood Johnson Foundation right now on figuring out some of those needs. And that's the baseline. Use that as your baseline to help you organize and figure out who needs to be at the table, and then play to those strengths. Because I'm finding that funders, even for our programs, are curious about where I'm partnering, where folks are doing this collaborative approach, because we've moved away from thinking it's a single intervention and it's a holistic approach.
Absolutely.
So just
Absolutely.
quickly,
Yes, Eric.
I was just saying, quickly following in that line of thought, realizing and the acknowledgement that ACEs don't happen in a vacuum.
Exactly.
And I apologize for I'm putting my COVID lens back on. That was a corny joke. Yes, back on. Because again, the kids started schools today. And part of the solution across the country, they were talking about kids need Wi-Fi access, kids need computers. And I personally, a group of friends and I found out about a family where a mom is living in a house with no electricity. She literally has candles on during the day. The kids are in the house, they were outside, they have computers, but they have no access. Even if you make it free for the entire city, they don't have electricity. Realizing that ACEs are linked to each other and having the forethought, like I've been kicking up and down and screaming like this is an ACE for everyone. This is COVID. This is a pandemic. This is happening to everyone, parents included. There is no parent blaming. We're all going through this. So talk to the kids, talk them through it, start working together, like Rochelle said, and like Phyllis had mentioned earlier, working together as a collective, as a community. What can we do to help each other? We know how to be villages. We've been villages for a long time, but literally trying to acknowledge the fact that this affects multiple, not that, just every aspect of our lives, and our kids can end up being the collateral damage. So just giving kids free computers, giving free Wi-Fi, that's not the solution, but just a full acknowledgement and taking a more comprehensive approach to ACEs in general, I think will be most effective. And I'll take my COVID. Enough COVID for today, sorry. No more COVID, sorry.
Do we have more time, Maggie, or are we out of time?
Well, we have maybe a few more minutes. We're actually scheduled for the next speaker at 11:35. So it has been so wonderful. Keep going for a little while longer.
Okay, super, thank you. Rochelle?
Yeah, what Dr. Griggs said, I think that's absolutely important. And I think, the acknowledgement that right now we're collectively going through an ACE, at Sesame Workshop, we're talking about that. This is collective trauma. Everyone is experiencing this, and we can't sugarcoat that. And it doesn't go by race or class or socioeconomic status. We're all feeling it, with full acknowledgement that the Black and brown community are feeling it a little bit harder because we're disproportionately impacted by all of this. And I think what's important is I want this, and I'm hoping that this is a moment that we can sort of take the barriers down on systems in particular. I should also, full disclosure, I used to work in government for 10 years in housing and social services, which is why I use words like systems and policy all the time. But I do believe those systems need to come together, right? COVID it's education, but it's also health. Are we all speaking the same language? Are kids and families experiencing the same things? And for me, it's the kids that aren't connected to these services that I worry about the most. And so that's why I'm always a proponent of this collective impact model and a community continuum of trauma-informed lens. Because imagine if you're not connected to services, but at your school, at your pediatrician visit, at your community-based youth group where you're playing basketball, you're playing soccer, you're still being interacted with adults who are approaching the trauma-informed lens. Now we're taking our work a step further, right? So now we're not, and I understand the need to sort of work with the kids that are the most at need, and they should be, but those kids are probably connected to services, some of them. What about the ones that aren't? Which is why I'm always curious about how do we transform school settings? Everyone's at school, which is a little different now, given COVID, but how do we get this into the classrooms? And so the more that communities can organize and leverage their local expertise, I think the more powerful we can be at addressing ACEs.
Yes, amen. So one of the attendees has asked a question that I'm going to throw to Ms. Cole. What, in your opinion, are the top 3 barriers to ACEs mitigation in the Mississippi Delta counties? Phaedra? If we would just unmute the panelists, and if the panelists would not mute themselves again, that would be wonderful. Just stay unmuted, please. Phaedra?
Yes, I'm back.
Did you hear the question?
Would you mind repeating the question? I think it was
just the top 3 barriers to ACEs mitigation in the Delta.
Oh gosh, access to care is going to be the number 1 barrier. We're in a very rural area. There's a shortage of mental health professionals in our area, particularly psychiatrists. So that is a huge barrier, and we're trying to mitigate that. And actually, the COVID pandemic, that's been one of the silver linings, is that it has increased our access to telehealth and telemedicine. So we've been very pleased to see leadership and the CMS and others sort of come to our rescue with that regard. We are hoping that a lot of those flexibilities will remain in place post-pandemic, because that certainly helps our access to care. Transportation, and that circles back to one of the comments I was making earlier, is that we've got to, again, shift away from this traditional in-office approach and meet the children and the families where they are, whether that's in the schools, whether that's at the Boys and Girls Club, linking with Department of Human Services and whatnot. We cannot simply continue to work in a vacuum. We've been very fortunate over the last 10 years or so to develop what's called Making a Plan or MAP teams. And in those MAP meetings, we convene, we're the host or lead agency, but we convene a task force of various stakeholders, whether that's the youth court counselors or judges, law enforcement, school personnel, DHS or CPS, and we come together about what we can do as an agency or as a collaborative team to help these children and youth that are at risk. And, you know, to be candid, we're really learning a lot about what other agencies do. It's amazing that when you're coexist in the same community, you really don't have an appreciation for what these other agencies do. So I think that's been a barrier in itself, is that there's not that widespread collaborative approach, communication going on among the different agencies as to how we can come together and tackle this as a unified team. We just worked in silos for so very long. So I think those are some of the greatest barriers.
So the need to build a system, a comprehensive system of shared knowledge. And as Rochelle said before, to understand the gaps that we have in knowledge is really important. But you've mentioned twice in your response to the question, this need to have greater access to mental health providers and simply the transportation needs that exist, because in some cases throughout the Delta, the populations are not so densely populated, but rather they're sparsely populated.
That's right.
And transportation is a big challenge. So thank you for your response. Let me just ask each of you, I don't see another question in the queue, this final question, and we'll end it after this final question. What kind of training, if any, have you observed or created that minimizes re-traumatizing young people? What interventions, if any, are out there that actually do not re-traumatize children? And I'm thinking especially about children in school, children when they visit the doctor, children who are food insecure and maybe have free lunch or discounted lunches. What kinds of interventions, if any, are you aware of that actually work so that they don't reinforce the trauma?
So to be honest, again, I'm not putting the glasses on, but just from the most recent things, and these are things I've seen on a level by parents and families walking their kids through this whole hybrid virtual school, virtual learning process, practicing wearing a mask for building up, starting at 5 minutes, then 10, then 30, then training them, letting them know. Like, I know one parent that drove to their school, was a kindergartner, drove to the school so they could see the school, walk around, and realize that we're going to start this at home. And they recreated everything that they could. I have another friend that mom decided it was a big deal to go to junior high school, and you get a locker. Well, they couldn't do it. So they made a locker for her at home to keep things as normal as possible. The trauma is the sudden change and unexpected change. So by literally going to the community and finding out solutions, setting up sharing, and I've seen that happen a lot amongst different families, like what do you do, best practices amongst families on the ground level, is helping a lot of kids just kind of ease into things so they're not re-traumatized.
Thank you, Eric. Rochelle? Caitlin? Yes.
Caitlin, you can go.
Oh, thank you. I just want to tell you about some of the work that we've had happen here in Louisiana. In schools in New Orleans, there was a trauma-informed schools learning collaborative that used several strategies. One was calm down corners, or in other parts of the state, they've been able to get a whole classroom so that when kids become upset or escalated, or they're just clearly not on the lesson, and the folks in the school who know them know that they've got something going on, there's a place they can go to practice self-regulation, right? And there's somebody there who can talk to them if they want to talk, but it's not an obligation. But it's a place to go to restore safety and to sort of process some of whatever it was that was interrupting their day without having to discipline, right? Without having to send them out of school, without having to suspend or expel. Another great program that we've seen happen in schools was in Shreveport. They found that their rate of in-school arrests was just astronomical and unsustainable. And so they worked with some local groups. One was called Volunteers for Youth Justice, to put in place restorative justice programs, conflict resolution, mediation, things like that, so that when what you're talking about is two kids get in a fight, what was happening previously was that they would get sent to detention. It would become a court matter, and then 9 months later, they would finally come up in front of a judge, and by then the whole thing would have been resolved, right? So it was, diverting funding from things that could actually be building resilience and addressing some of, keeping kids in school and keeping them learning. And at that point, the courts were like, why are you here? What can we do at this point? So now when there's a fight, when there's something that could have previously become an arrest, now they go to conflict resolution or mediation. In New Orleans, they use some restorative justice circles to deal with conflicts, where maybe the family is involved. There's different models for how to approach this, but to actually create resolution and not just discipline and eject, right? To actually maintain community connections, even when there is a disruption or when something is going on, and respond to that through supportive, caring, nurturing relationships in a way that creates growth and learning and resilience, and not, doesn't fracture relationships that youth need.
That's super. Thank you, Caitlin. Rochelle?
Yeah, I piggyback and echo a lot of what Caitlin said. I think it's about how do you help the adults in kids' lives, especially parents as well as caregivers, create nurturing connections, and all of the materials and things that we offer are all about bolstering those connections and really modeling for parents and caregivers the protective factors and how to comfort kids. And I think in addition to the resources, we also, similarly, you call it the calm down places, we have something we call Comfy Cozy Nests. And so building off of that trauma storybook I mentioned with Big Bird, where he's feeling unsafe and Alan walks him through, when you feel unsafe, what brings you comfort? It's a teddy bear. Is there a certain part of your home? You bring your blanket, your favorite comfort items. If you physically can't have those things, how do you go in your head and kind of imagine those things? And it's a way of creating a sense of comfort for children. And so we've taken that concept and with some of our partners created those spaces in the unlikely places where kids are served, so we're not re-traumatizing, right? And so particularly we have a partnership with the National Association of Drug Court Professionals, because we know that children often go to these court appearances and those are not fun places, not for fun or adults, neither are they for kids. And so we created some comfy, cozy places in drug courts where it's our resources with additional resources, just so that it's a more welcoming environment and really talking kids through it. And so I think that it's important for all of us to get creative and how we do this. And one of my partners, to be honest with you, took it a step further than us. They created a mobile comfy cozy space. We never even thought about that. We were still thinking physical spaces, but sometimes you need to take vans and you go to where the people are, you know, like Phaedra mentioned. So they're at the block parties, they're at the school locations, they're at the supermarket, and then you're coming in. And when you come in, it's, you know, it's systematized, as we like to call it. It has the characters, it has our books and resources, but what's important is it's matched with local resources as well.
Wow, so we've had a brain trust of folks who care and are knowledgeable, and that's always the best combination. And I know that many of the themes that you've broached in today's panel will be questions that our attendees will have, at least for the rest of the afternoon, and perhaps when they go back to their own programs to build stronger interventions. And so I think by way of summary, I'll say that everybody needs Big Bird in their lives, children and adults. We all need Big Bird. We will never, ever not need a hug. We will never, ever not need one caring guardian or person in our lives. And if we can build interventions where trust is sort of the core foundation, and build safe spaces for children to exercise their own autonomy and talents, they can, if they've experienced ACEs, they can reconcile that and live good and productive and flourishing lives. And that's our hope and that's our expectation. So thank you all, you were wonderful.